I'm Bill Padula, an assistant professor at University of Southern California, and we also have with us Peter Pronovost, the Chief Quality Officer and Chief Clinical Transformation Officer from University Hospitals. I'll get us going on this paper today about value defects in the health services sector, and then Peter will bring us to the finish line. The wasteful spending in healthcare probably doesn't need a huge introduction to this audience, particularly going back to the JAMA paper from Berwick and Hackbarth, citing that healthcare spending has tripled over the last decade, and a lot of it has to do with spending on waste. A more recent paper in JAMA from Schrank and colleagues cites somewhere between 760 and $935 billion on wasteful spending. And I want to point out here, Peter and I have put our heads together and think normally economists always make conservative estimates about spending in healthcare. And I think this is a conservative estimate too, perhaps a lower bound on what we could potentially be spending upwards of $1 trillion in wasteful spending, whereas we only spend somewhere between 190 and 280 billion on the quality improvement programs to fix wasteful spending. So there's got to be some equilibrium that we haven't found yet where spending on quality improvement could reduce waste down to a more minimal amount. Next slide. You know, this is a point that Mark made early on here, but when you have to figure out where is waste coming from, the best place to start is the health services sector. Like he said, we only spend about 1/5 of our healthcare dollars on prescription drugs compared to the bulk of the money where it's spent in physician services, hospital care, home health care, and the like. So if we're spending multiple trillions of dollars in these areas, then there's probably more waste to be had. And I believe that the illustration on the right of where we spend in chronic conditions really is indicative of where most of the waste is going. Over 50% of Medicare dollars are spent on 14% of its beneficiaries with 6 or more chronic conditions. So it's that chronically comorbid patient that perhaps is where there's opportunities to save on wasteful spending. Next slide. And so with that, Peter and colleagues at University Hospitals Cleveland developed this really nice, eloquent framework referred to as value defects, with the idea that we don't necessarily have to cut costs in order to remove wasteful spending, but we do have to design the system differently to deliver higher value. And that's done through these 5 domains that are to empathize with users of the process, define users' needs, problems, and your own insights around them, ideate by challenging assumptions and generating ideas for innovative solutions, prototype rapidly and start creating solutions, and finally, to test those solutions to illuminate how best to configure them. With this framework, we can identify areas of wasteful spending and implement higher value healthcare solutions in the services sector potentially to address wasteful spending. Next slide. And so from that framework, we came up with this value defects cost effectiveness plane together, where we cite potentially, not necessarily perfectly to scale, but where the major value defects may lie in this realm of losing clinical benefits and overspending on healthcare that is not delivering good value. And these value defects include avoidable post-acute use, difficult access to specialty care. We believe that those are potentially cost-cutting solutions, but they're not adding clinical benefits. And then in the no value care realm, where we're spending more and losing clinical benefits, difficulty supporting shared decision-making, care with avoidable complications and preventable readmissions, and inappropriate care, some of the more obvious ones that we've talked about for decades. And then finally, things where marginally we're spending more to get clinical benefits, but the costs may exceed the value of those benefits, where we're spending on low volume procedure at low volume facilities, and low value sites of care kind of go together well. So we've thought about this, and this is recently published in a New England Journal Catalyst paper that Beth is able to post the link on in the chat for this presentation. And as we move into the next slide, and Peter will pick up on this discussion, welcome your thoughts.
So Bill, thank you, and thank you all for having me here. as many of you said, as a clinician, I've been frustrated about not being able to improve value and moving beyond theory to actually making progress in that. And our way of approaching it was to make this checklist of defects in value, or a framework, and then make them visible and transparent so we could look about how to design care around patients' needs and anchor it in primary care to try to eliminate those. And I want to share with you some of what we've been doing at university hospitals. Next slide. The paper, and it just reiterates what Bill has showed, this defects in value framework looks like it is about $1.4 trillion, or again, 30% of the healthcare costs. But largely, these are invisible for anyone in the healthcare system, except if you're paying the bill. But even then, you don't know where to target the efforts. And so we really wanted to get granular. Next slide. And so we challenged our organization to say, okay, we're all going to align around this opportunity to maximize value, and that we created an analytic framework to make these defects visible, and then design our management systems to reduce them or eliminate them. We had to align some of our incentives with our physicians to make sure that they were becoming top priorities, and making sure that we were better able to attribute our population to the individual clinicians. Next slide. The defects in value framework, it's not rocket science, but it's really powerful for clinicians. We're organizing it into preventative care, getting well, so looking at annual wellness visits. For example, and I'm going to share data over 2 years, data paper that was just accepted of Journal of General Internal Medicine, annual wellness visits across 500 physicians and 100,000 patients went from 14% to this year, thus far, 68%, using this approach, as well as increasing cancer screening and blood pressure and diabetes control, and helping people get well. So for any chronic disease, and you look at diabetes and we measure A1C, but we know 40% aren't diagnosed. We know 8% are on the right therapy. We know 11% have their physiology controlled, and of those who don't, at least half are just not able to get the therapy for a variety of social reasons. 80% or more have high ED utilization, half have behavioral health needs, and 2% get those needs. So our diabetic care program was laserly focusing on every one of those steps in this continuum. I'll give you one example of this designing care for behavioral health. We had preciously little access to behavioral health, and if you did, it was a 6-month wait to a specialist psychiatrist. When we did design sessions, we said 50% of behavioral health could be met by social worker, and so we deployed those in primary care practices. The next 30 or 40% could be met by short-term consult with a psychiatrist. We call it access clinic, where we're guaranteed to be seen within a week for up to 3 visits just for a diagnosis and treatment plan, and get them back into care. And then the last 10% need chronic care management, where we stood up behavioral health hubs, right? Radically rethinking, just reallocated our workforce and went from essentially no access to pretty uniform access within a week. And then defects in getting better, that is for acute conditions that Bill has already gone through. Next slide. I want to just share with you the summary of results, because these improvements in value happened with no change in the incentives from CMS. We did change some incentives for primary care, but they were trivial, but they happened by redesigning care. And I think, though we focus on payment policy, I think we also need to focus on quality improvement and care delivery. And so, as you know, on these QR cards, quality is the x-axis, cost is the y. We look to be in the lower right-hand quadrant. Next slide. And this is just year by year. 2017, we were over $10,000 per cost of care, maybe the worst 20% of the ACOs in the country. 18, we introduced this approach, moved a little bit on quality, slightly on cost. Next slide. 19, big improvement on quality, some further improvement on cost. And 20, despite COVID, now 100% on quality with the handful of ACOs that have that, and a cost that is now $8,200, $2,200 less than they were in 18. So what that says is, in a large Medicare population, reducing cost by 21% while improving quality, while by systematically breaking down these defects in value, making them actionable, and designing management system to close them out. So I say, in building on what Bill said, to close, we're hopeful that there are some ways that the delivery system could redesign care for much higher value than it delivers now, but humbled in that this is 20% cost reduction. And if we think 30% is what's waste, when I look around and see the enduring waste and opportunity of existing defects in value, my friends, I think it's far higher than 30% if we're really disciplined about labeling these defects in value and what's possible. I think it's probably 40 or 50%, quite frankly. And with that, I'll close. And Bill, if we have time, I'm happy to take questions.
Thanks, Peter. And thank you, Bill. Mark Fendrick here. So I've been an admirer of both of your work for a very long time. Very provocative comments. I think the first one, which is being kind of distilled by the audience, is the great Upton Sinclair said in the book, The Jungle, published over 100 years ago, it's difficult to get a man to understand something if his salary depends on him not understanding it. And I'm curious, first starting with you, Bill, and Peter, you could chime in because it was one of your key messages in your framework, is you did mention incentives. And as long as our specialists, for the most part, continue to get paid for doing everything they want to do, regardless of its impact on quality and cost, what do you think was the key motivator that led to those quality enhancements, but also cost drivers, since most of the things we beg our patients to do, Peter, are cost effective and not cost saving? So Bill, I'll let you go first, and Peter afterwards.
Yeah, I think that a lot of the value defects map onto some of the cost consequences that payers such as Medicare have set up in their system. You know, you see now that patients who get inappropriate care, have a preventable readmission, or are harmed by a hospital-acquired infection or fall or so forth, those hospitals are getting penalized millions of dollars a year. And so there's equal-sided risk here to take, and you can pay the penalties and pay for the cost consequences of poor outcomes, or you can generate better revenues by doing the right thing for the patient, turning them over quickly and having the next patient who needs help come in. And you're not using up all the resources on the first patient and losing out on the opportunity to serve other patients that are in need. And of course, we're seeing that in spades right now with COVID, where there's a much greater demand for healthcare than there are providers and beds to serve those patients.
Thanks, Bill. Peter?
Yeah, and Mark, I would just add, because I think it's important, the only incentives that we changed was a small incentive to primary care doctors to do annual wellness visits to code HCC, so we got revenue in our MA plans, and to control diabetes and blood pressure. And what we shared with them is to say, we're betting that you're going to do that, and that funding source that we hope continues year after year will be contingent upon us hitting shared savings and other, these ACO programs. It was a few $1,000s. It wasn't that much, but it was the first time our primary or any of our health doctors were created a value incentive. It was completely fee for service. We didn't change the incentives for the specialist market. We did something really innovative. In these design sessions for behavioral health, for diabetes, we now did it for heart failure. What we found is that our specialists admitted they were wasting their time seeing people where they could, if they weren't on a fee-for-service chassis, could see higher value patients. And so what for our endocrinologist to control diabetes, for a nephrologist for hypertension, what I said is, okay, I will buy, some of your time, and you need to work with us to say every uncontrolled diabetic is, make sure they get into primary care, they're seen by a pharmacist, and you are that pharmacist backup to make sure they have the right medication management. And then same thing for behavioral health, that people who screen for behavioral health needs, you need to make sure they get into either a social work or your access clinic, and no upside incentives. Just I got them off the hamster wheel of RVUs, and they are like so joyful. It's so meaningful for them. And you know, our performance on those no doubt contributed to these annual savings. And I say that, Mark, because what we've done now is negotiated with some employers and some commercial plans for doing pro fee cap for the 1% of patients, where we stood up a clinic that's just literally showing 50% reduction in their spend for diabetes care, where the pro fee cap includes a nutritionist, a social work, some of the physician time. The same thing with that 1% clinic. We see them as often as we need to get their physiology controlled or whatever needs they meant, but it covers the whole care team. We're quite excited. We don't know enough to take downside risk on those yet. I'm pretty comfortable because we've seen great savings that we will, and we'll have a robust enough economic model to price it. But right now, I think there's a lot of progress we could make if you can just solve the pro fee problem to put the right care team for these people.
Great. So in 1 minute or less to each of you. So there's some questions in the chat. So some of you who know me know I tend to be a little overly half glass full person in looking at the silver linings of things, and wrote with colleagues David Kim, Dan Ohlendorf, and Peter Newman a piece early on in the COVID pandemic on how we could use this as an opportunity to really think about value reallocation. I'm curious, both of you, is one, given all the abrupt changes that have hit the delivery system and all the new models being delivered, where do you think we're going to come out of this in terms of value in the post, if there is a post-pandemic time? And specifically for you, Peter, there was a question about whether you feel the ACO model is the one that is best suited for this, or if you're kind of more open to other opportunities for alternative payments. Bill, you first, a minute or less.
Well, I think the economic model that Peter and I just published on managing COVID patients in the outpatient and emergency department volume speaks volumes to where we're going with telemedicine and technology that can help us handle patients without needing them to come into the health services sector. You know, as we've known since crossing the quality chasm, patients that stay out of the healthcare system are better off and they save us more money. And so if we can manage using telehealth and good technology moving ahead, which has really made great strides in the last year during COVID, then I think we'll be better off and avoid more value defect opportunities.
A fellow optimist. Peter, final word.
Yeah, and I would agree. I think COVID has done more to drive value than virtually any other thing. Not so much of macro payment reform, some micro payment to allow better payment for home care or home monitoring. But what it did was it changed the paradigm that success needs to be keeping people healthy at home rather than healing in hospital. And that was driven by scarcity of PPE. It was driven by shortage of beds. But now we've gotten comfortable that we can do those models and we could design systems to keep people at home. The ACO question, I think you're absolutely right. There's other models, and MSSP is risky because the benchmark's set retrospectively, so you don't know, you can't forecast the budget. But I do think whatever it is, having patients attributable to physicians is the absolutely key. So I could align their incentives and we could manage them and hold people accountable for driving performance.
Thank you both so much. What a great kickoff. With that, I'm going to turn the microphone over to our colleague, Brett McQueen, who will speak to the challenges and potential solutions to measuring effectiveness of health service interventions. Brett, it's all yours.
Yeah. Thank you, Dr. Fendrick, and really appreciate the first talk by my colleagues. That was really, really fascinating. So yeah, I'm Brett McQueen. We can go to the next slide. I'm assistant professor at University of Colorado, and just want to thank all of you at Altarum for funding this project, and just acknowledge some conflicts that I have in the field. Next slide, please. So, I'm going to focus in, this will be less high level and really focused in on effectiveness, because I don't think we talk about it enough. And this isn't a surprise to everybody, but health service interventions are underrepresented in cost effectiveness as a proportion of spending. And you might think, well, yeah, that's because of regulatory approval requirements. And I'm actually going to argue it's more challenging than simply regulatory approval. And one example that we often talk about is different cost of services by city, right? There's always some publication or some Times article that comes out and says the cost is different. And the discussion often ends with simply talking about that cost difference. No context of value. Is it worth more in San Francisco? Do you get higher quality? Do you get better outcomes versus Denver or Boston or Nashville? I mean, if you can see and you know kind of the cost of living in those cities, it's not just ranked by the cost of living. So it's really interesting that the discussion often ends. And that's because we don't have the other side of the equation. Next slide, please. And there's difficulties that I cover in the blog post. This is not an exhaustive list. Everyone knows that, but I think these are 4 key difficulties in measuring effectiveness. The first one is really distinguishing effectiveness from broader concepts like quality of care. It's not to minimize quality of care. It's that it's so multidimensional that effectiveness is sort of a domain within that broader quality. Health outcomes that matter most to patients, measuring those outcomes. And I know my colleagues from NHC and PAVE are going to be talking about that a little later. So I'm just going to touch on that briefly. Design is always an issue, but really the one that I dug into on the post is measurement challenges, because it is really challenging to actually make all of these links from, for example, an upfront screening procedure. And this is an example of my own work and some of my colleagues in Colorado, where we tried to establish this link between childhood screening for pre-symptomatic type 1 diabetes, and then associating that with the really the intervention, which was monitoring and education, and then lifetime risks and survival. It's a really big challenge. And we made a lot of leaps, but we were able to ask different questions, like how cost effective would this be if we reached some clinical benchmark of effectiveness? And I think we can get around some of the challenges with some solutions like that. Next slide, please. So the first one that I just spoke about is defining effectiveness of health services. And when you dig into this and you look into the literature, you think program evaluation, quality, but we're talking about effectiveness in context of value. Can we actually have that as an input to comparative effectiveness, cost effectiveness? And obviously the definition, I'm not trying to be controversial, it's just there are so many definitions around effectiveness. But in this context, I'm talking about the impact of a health service intervention on health outcomes important to patients in actual clinical practice settings. Next slide, please. So what health outcomes matter most to patients? I always like to go to NHC's website because I think they have a lot of great, not only outcome definitions, but the instruments that flow into defining those outcomes. And they'll be speaking later, but I just want to touch on the obvious fact that we actually don't really collect evidence on effectiveness in context to these different definitions, like the broad range of impacts a disease and its treatment have on a patient's daily life. It's actually quite complicated to measure that, but we just haven't tried, I don't think, in my opinion. And then the International Consortium for Health Outcomes Measurement has kind of a similar definition with just a few more words placed in there. Next slide, please. And then design is obviously a big issue. I'm not trying to downplay it. It's just that there are so many solutions with observational data. Randomization is, of course, ideal, but health services, as I just spoke about, are not required to undergo the same regulatory approval steps. And this is an example from one of my colleagues who just did a fantastic randomized trial on palliative care, like a team-based outpatient palliative care model that was essentially increased personnel, social workers, chaplains, additional advanced care planning, and they had all sorts of patient-reported and caregiver outcomes. It was so well done, but I would argue that's the exception, not necessarily the rule. And if you're in that area, this is a really great paper, and Dr. Kluger's really well known in that field. So it's obviously more feasible to rely on observational data sources, but health services and the econometrics literature provides a wealth of quasi-experimental solutions for us. I didn't want to cover too much of that because I think other authors have done a much better job of that. Next slide, please. But what I did want to touch on quite a bit was actual measurement of exposures and outcomes, because they really might reflect simply what's reimbursable. And the example here, my colleague Bill Padula works heavily in pressure ulcers. And this paper is so fantastic because it actually shows, when you look at surveillance data where the actual objective was to collect hospital-acquired pressure ulcer information and outcomes, it's so different than administrative data. They're just not the same. You don't pick up the same frequency of pressure ulcers. So this is really important for researchers to know, hey, when you're actually looking into an administrative data, you've got to supplement that information. Otherwise, you're literally missing outcomes. I don't care how well you've designed your study, you're not going to answer the question very well. And then on top of that, there's very little information on severity of diagnoses, patient-reported health status. Again, those health outcomes that matter to patients. Next slide, please. And sort of with a turn to the future, I've done a couple of different time and motion or time-driven activity-based costing exercises. The one thing that I've kind of understood from those exercises is when we measure the full cycle of care, I understand all the different exposures, whether that be personnel, procedures, labs. We understand more what's going on at the patient level. So yes, it's been designed to work as a costing tool, but through that process, we've realized, hey, maybe we can target a patient-reported outcome tool here because there's a time gap that really can't be dropped to any lower than 5 or 10 minutes. That's a good place to get a response from that patient. And I leave a quote from Donna Bidian, who really kind of wrote the first paper on quality of medical care. And I just think the quote is really relevant, that often we go to what is wrong. And instead, shouldn't we really be talking about what goes on here? What's the whole process? And I think it's just still relevant to this day, and we should be doing more of this. And I have a couple of, I would say, in press work on this area. It's really fascinating. Next slide, please. So where should we go from here? I'm not going to sit here and tell you this is a very easy solution, because it's not. But for researchers, I think we can do a much better job of distinguishing between overall sort of broad concepts of quality and separately from effectiveness. I also think when you're working with administrative data, you should acknowledge you're probably missing outcomes. In fact, you might be missing outcomes and then the severity of those outcomes. Providers, it's going to be really hard to change behavior without legislation. Obviously, I would urge hospitals and broader groups, not just at the physician level, to define your exposures and outcomes beyond just simply what you have to report for regulatory requirements or for your own sustainability efforts. But the biggest one, I think, is funders. We need to continue, for example, PCORNet, some of the work that's already been done out of PCORI. We need those common data models. We need to incentivize those common data models, but supplement them with understanding the full cycle of care, measuring outcomes important to patients. Only then will, I think, we really see more change in this area. Next slide, please. So just a brief summary and conclusions before I move on to kind of our next step on this work. Given the scale of spending, I really think this should be a national priority. I realize it's very difficult and it's not going to be a very easy venture, but I think we should be demanding more. And even with that significant investment and collaboration, we always talk about producing value, and instead of quantity, or but instead of just producing quality metrics, we could actually be producing value if we have more information that we can collect at that level. Next slide, please. So next steps, my colleague Bill Padula and then Natalie Reed are going to write a final post in the series that kind of sort of merges a lot of the different concepts that we've talked about. All the speakers today are going to be talking about, called a roadmap to high value healthcare to complete the series. Can we prioritize wasteful spending, really, and identify what flows into value assessment, what actually can be used for a cost effectiveness or maybe budget impact analysis, or just simply a comparative effectiveness analysis, and what sort of gaps do we still have? I think that's going to be a nice next step for a lot of people, including, I know, myself, who's looking to do more work in this area. So thank you very much, and really happy to be here.
So very insightful, and thank you for that. Sparked a lot of interest. So a couple things. I applaud you for putting patients first. I like to tell audiences that I didn't go to medical school to learn how to save people money. And I particularly appreciate, Brett, you calling out both Professor Donabedian and my colleagues from Michigan with their Presser ulcer paper. So don't know how fond you were of the U of M Wolverines there. So thank you for that.
Yes, of course.
There's a whole bunch of themes here. I'll start and look at the chat for other comments and questions. But the point that you make in the previous speakers, that there's a whole lot of spending in the US that don't even meet the effectiveness bar. So we don't need value, right? And one of your three last priorities was to remove wasteful spending. And we at the consortium have spent a lot of time, and we have created a low value care task force to bring together multiple constituencies on these fruits below the ground, and wonder if you have any particular advice for us, how we might want to not just go for the low-lying fruit, but how about the fruit below the ground? The U.S. Preventive Services Task Force D-rated services, or those services noted by professional societies themselves, like Choosing Wisely. We haven't done very well in terms of removing these things that appear to be no-brainers.
Yeah, and I know there have been a couple of papers out there that say, look, we're still using just awful services that they might actually be more harmful. And your group has obviously been pushing that forward for years. I mean, I think my only bit of advice, which comes with a big caveat, is sometimes we actually don't have the effectiveness, at least in context to this talk, we actually don't have the effectiveness estimation to say, this is not cost effective. We might say it's not effective or on these broader quality of care outcomes, but can we actually define that it is worse for the patient? I don't actually think we have a ton of that evidence in the field, even though everyone knows and everyone kind of understands that these low value options are actually almost harmful for patients. We have to prove it, and we really have to show it. And without that regulatory approval step, it just is really challenging. So it's probably sort of a sidestep to your answer, but
no, not at all. I mean, given your broad view, which you know how much I appreciate and understand, have been supportive of your full cycle approach, even though there's lots of impatience among academic communities and federal agencies because they want their answers now. But do you see an appetite to actually see a movement to start not only pushing for increased spending on the high value services, which I think is getting there, but you had mentioned maybe we could start holding providers accountable the same way we do to doing a better job in high value services, but also benchmark them on how they're doing with low value care as well.
Yeah, I mean, just like in cost effectiveness around biopharmaceuticals, there's only so much we can do until legislation helps basically get cheaper drugs to patients, right? Spend less. It's the same with health services. We have incentives at the hospital level that can be quite challenging. And I've personally kind of been involved in those at our own institution. And it's a big lift to get people at the sort of administrator level to care about this. Because as you said, you know, it's early on in the process, it's somebody's salary in the end. But absolutely all the physicians on campus that I work with, I'm overwhelmed with responses because we actually costed that palliative care intervention that I just spoke about. There's a huge appetite at the physician level. There are even funding agencies that are demanding that. So if you look at somebody like JDRF or Helmsley Foundation, they're actually demanding that something has to show some value or sustainability to the system as part of the grant application, forcing almost or incentivizing physicians to say, okay, we really have to talk about this. So there is, and it has grown just since I've been in academia, which hasn't actually been that long. So it is moving, but in the end, incentives have to change up top.
Brett, thanks very much. Really great. Can I have the next slide, please, Holly? Thank you very much. Happy to turn the mic over to Chris Whaley of RAND, who will be speaking on sources of healthcare price variation create barriers to measuring health costs. Chris, welcome.
Thank you, Mark. I'm a health economist at the RAND Corporation, and really excited to talk about these topics and present to this group. Next slide, please. The topic that I'm going to talk about today, and that a lot of my research focuses on, is really the employer-sponsored market. And so these are individuals, like I'm sure many on the call, who receive health insurance coverage through an employer. Collectively, employers provide insurance coverage for about half of everyone in the United States, about 160 million people, and collectively pay about $1.2 trillion in healthcare costs per year. So that's a huge market and a huge amount of money that covers lots of people. About half of that chunk, and the majority of that chunk, just under $500 billion, goes towards hospital care. And so this is a huge market that is a key source of insurance coverage for many, many people in the United States. Next slide, please. As many on the call are aware, this is a market that, in addition to being large and important, has also faced challenges. And I think these challenges have real economic consequences that aren't really appreciated. I mean, a lot of times we talk about healthcare prices and kind of focus on healthcare within its own vacuum, but I think it's important to recognize just how healthcare is financed in the United States, especially through the employer-sponsored side, and what are some of the impacts of many of the things that we talk about just on healthcare and how those might spill over to other parts of the economy. And so just to highlight that, this slide uses data from the Kaiser Family Foundation and just looks at how employer benefits have changed over the last decade. Over the last decade, deductibles, so the amount that employers pay before insurance even kicks in, have more than doubled and almost tripled. There's been about a 50% increase in premiums. It now costs, I think, around $22,000 for an employer to provide health insurance for a family. And so if you're a low-income worker, it's easy to see how that's at least half of your salary going to health insurance. Inflation has increased by about 25%, and worker earnings have decreased the lowest at just about 20%. And so there's a growing concern shared by many, myself included, that we are essentially financing healthcare costs and rising healthcare costs by taking wage increases out of worker pay and giving it to workers in healthcare dollars instead. Next slide, please. And as we focus on just kind of the complexities of this market, it's important to just think about prices and how prices are allocated and determined in this market. And so this is going to be very similar to what Brett discussed, but when we just look at the landscape of healthcare prices, it doesn't make a lot of sense. And so this is using data also from the Healthcare Cost Institute and featured in the New York Times that focuses on negotiated prices for just a very standard lab test, a metabolic panel. This is probably the most commodity service in medical care. And the range of prices are just all over the place. So for example, in Miami, prices range from $725 to $149. If we go down to Portland, prices are $15 to $44. It's hard to tell an economic or story that makes any sense of these price differences, which I think contributes to the issues that I highlighted on the previous slide. Next slide, please. And the range in price variation doesn't just exist across different markets. It also exists within a given market. So for example, using data from the Blue Cross Blue Shield Association, if we just look at knee replacement prices, the average price for a knee replacement in the US is about $35,000. If you go to San Antonio, the range is from about $20,000 up to just under $90,000. Whereas you go to Pittsburgh, Ohio, or Pittsburgh, Pennsylvania, sorry, relatively, similar size city, also home to large providers, the price variation is much narrower. And so this is a landscape that you think would be an opportunity maybe for patients and employers to navigate. And if we're thinking of any other market, this type of variation maybe wouldn't exist, and there might be opportunities to actually shop or to take advantage of some of this price variation. Next slide, please. And so there's been a lot of calls that we need to have maybe more price transparency or more information about prices. And I think it's important to keep in mind here is that in many cases, providers really just have no incentive or reason to care about prices. And I think a good just example of that is from a paper from a couple of years ago in JAMA Internal Medicine, where researchers called up 20 hospitals in the Philadelphia area and asked for two things. So one, what is the price of an electrocardiogram? So again, a very standard service. Every hospital in the country does these every day. And two, what is the price for parking? In case you're worried about insurance benefit design and maybe insurers negotiate different prices with different hospitals, the researcher said, simply, I don't have insurance. How much does it cost me to pay? And so out of these 20 hospitals in the Philadelphia area, only 3 could give price information about the service that they actually do, electrocardiograms. And the price ranges from about $130 up to $1,200. On the other hand, every hospital was able to give information about parking, except for one. And as you can see here, the amount of detail in the schedule of prices is very intricate, and this is something that hospitals had offhand. And so in this type of market, it's really challenging to think that patients are actually going to be able to navigate the extreme levels of price variation that I highlighted in the earlier slides if providers can't even equip or not equipped to give patients information about prices. Next slide, please. And so what's different about healthcare? We don't see these same types of situations in really any other market. And so I think that there are really kind of 3 main reasons that healthcare is a lot different. So the first is that compared to essentially every other market, as I highlighted earlier, there's just not a ton of information about prices. There have been a lot of efforts in the last couple of years to kind of fix that, and maybe some of these efforts have been a little bit over optimistic. And it appears that if we give patients information about prices, that still doesn't radically change their behavior. And why is that? Well, unlike every other market where you're actually making financial decisions on your own behalf, in healthcare, and especially in the employer-sponsored world, insurance coverage tends to be relatively generous. And so if you just pay the same copay or co-insurance regardless of where you go, as a patient, why do you even care about prices, especially if you think that there's a pretty strong link between price and quality? And so in healthcare, unlike many other markets, there's really not strong incentives to shop. And so it's not clear that if we just kind of flood the market with information about prices, that's actually going to actually lead to radical changes in the levels of variation that I highlighted earlier. And then a key other reason is that there is a reason that doctors and healthcare professionals get lots of training, and patients don't have that same level of training. And so if you're a patient, even if you know levels of prices and kind of the detailed information about prices across different providers, it's not clear that you actually have the ability to shop or to make those types of medical decisions. And then in addition, many patients get access to providers or to hospitals and laboratory tests, et cetera, based on referrals from their provider. There is a rapidly consolidating provider market, And that has raised concerns that vertically integrated or consolidated providers are going to limit some of the choices for downstream care for patients. And that's something that some of my research and the research of others has documented. And then also another barrier is that within many insurance systems, it's really hard to compare prices based on some of the contractual language that insurers have with providers. And so in a typical model, insurers negotiate prices for individual services and compare prices across, set prices across different hospitals or physician groups, et cetera. And then they work with employers to actually gain access to this network or this system of negotiated prices. But many of these contracts actually have gag clauses or contractual limitations that actually prevent kind of a wider disclosure of prices and the ability of highlighting levels of price variation across different providers. And so this kind of contractual secrecy really makes it difficult to have an honest conversation, whether it's the patient side or even at the policy or research side about levels of provider prices. There have been a couple of policy changes that have tried to address this. So I mentioned earlier, there have been lots of, or some private tools that have given patients access to price information. Those haven't been too successful. There have also been public policy changes. So for example, federal legislation that requires hospitals to post prices. This has been something that really, both from the implementation side and kind of a policy change side, hasn't had a tremendous amount of success, largely because it's not clear that these policies are that well designed or implemented. And so just to wrap up, there's lots of concern that rising healthcare costs are placing downward pressure on employer wages. And I think this is especially true during the pandemic. The glass, just to keep it the optimism side, the glass half full viewpoint is that, well, if we can do something about prices, that the wide variation in prices just creates a opportunity for savings. And then also there's got to be more effort by healthcare purchasers, whether it's employers or other groups, to push for data that they and the workers are paying. Thank you, and happy to answer questions in a couple minutes.
Thanks so much, Chris. You tried your best to be a half glass full guy, but there's the Tigger and 100 Acre Wood. That was a little bit of an Eeyore story there. I'm sorry to say. We really, really appreciate your groundbreaking work in price variation, and the speakers that are coming after you have been, compiling tens of thousands of cost effectiveness analyses, and they probably have one price as opposed to the wide variations on everything that you've discovered across the entire spectrum of care. But let me just ask you, the work that you've done have led to these policies regarding transparency. You've seen very much a lot of increased fines to try to put more leverage on this price transparency information. What's your view even if prices became completely transparent about how impactful they would be, given the very scanty evidence to show that most Americans are willing to be aggressive shoppers and largely going to follow what their clinicians tell them to do?
Yeah, so I really go back to the slide I had in the middle of my presentation, where if we're going to do something about prices, it's really this three-legged stool. And so if we just have totally transparent prices, that's going to be great for researchers and people in the media who write these stories or write stories on highlighting price variation. But from the patient perspective, they're still not going to have the financial incentives to really care about prices. Unless, as Corinne mentioned, we implement things like smarter deductibles or reference pricing. And even then, they're still going to face a rapidly and very consolidated provider market that in many cases limits their ability to actually do anything about prices and to strategically shop.
Thanks very much. I'll view that as a little bit more than half full. Thanks. Great presentation. And man, the time is just flying by. So I'll be quick. I wish I had more time to introduce my longstanding colleagues, Peter Newman and Dan Ohlendorf from Tufts Medical Center, the keepers of cost effectiveness information from around the world. happy to have their dog and pony on enhancing healthcare value through data measurement and evaluation of services and procedures. I think, Peter, you're going first, but I'm not exactly sure, so I'll leave it up to the two of you to decide who's going to start.
Okay, well, thanks so much, Mark. Really good to be with you all. Thanks also to Altarum and Pharma and the Pharma Foundation for funding some of our work. So we've already been discussing the fact that most cost effectiveness analyses don't pertain to services, health services, and procedures. So I'm going to elaborate on some of that and show you some data, and then discuss with Dan Ohlendorf, who will be part of this presentation, why that is and what maybe we should do about it. So we have three things to really present today. First of all, a little more on the fact that cost effectiveness analyses focus mostly on pharmaceuticals. Second, why the understudy of health services and procedures. And finally, some thoughts about what we might do about that. So let's start with this idea that cost effectiveness analysis focus most on pharmaceuticals. And Mark has already mentioned, we have a large database, as many of you know, of published cost effectiveness analyses in the form of cost per quality. So what you're seeing on this slide is on the x-axis, the publication year, on the y-axis, the number of studies, and we have the cool animation here. We can show you there's been a really dramatic increase over time in the number of published cost effectiveness analyses, as you can see on the graph. In fact, we just hit our 10,000th study that we entered into the database. So really proud of that. And the data span a wide range of diseases and a wide range of interventions, although it is somewhat lopsided in that many of them are on pharmaceuticals. And just also, we have, in addition to the 10,000 studies, 24,800 or so cost effectiveness ratios. So many of these studies have more than one ratio. So there's just a wealth of data. And we also collect the data on the preference weights, the utility weights, and the 36,000 of them. If anybody's interested, you can certainly Google CEA registry and find out a lot more information and search for yourself. But the point we really want to focus on is this phenomenon. Most of the studies, or not most, but many of the studies focus on pharmaceuticals. And you can see in this graph, roughly 40–50% a year focus on pharmaceuticals. It bounces up and down a little bit, but really a pretty steady trend. Around 40, I think the total is now 43% focus on pharmaceuticals. Now, depending on how you define terms, drugs, about 15 to 20% of health spend, really depends on what you're including in the numerator and, for that matter, the denominator. But you see these numbers bounce around. 15 million, 20% of total health spend is pharmaceuticals. So there's a discrepancy. And the key takeaway, pharmaceuticals comprise 15% or so of health spend, but 43% of these studies have focused on pharmaceuticals. Another 10 or so percent on diagnostics, by the way, and roughly 8% or so on devices, but a relatively small fraction on where the bulk of the spend is. That is on what goes on in the hospitals and the physician offices, namely procedures and services. So why the understudy? And Brett, and I think even Chris mentioned a bit of this, but this is our take. To explain the understudy, two broad categories. One, lack of suitable data, and two, the nature of the intervention, meaning the nature of the pharmaceuticals and the nature of services and procedures. And of course, these are related to some extent. But turning to data, and we've heard this and we know this, there are fewer randomized trials on services and procedures. Of course, there's some, and Brett showed a very nice example, and we see these. But for regulatory requirements, you have to have a randomized trial for a pharmaceutical, and you really don't for most services and procedures, even as we have some examples. So if you need an effect size for a cost effectiveness analysis, you have to get it from someplace else, typically for a service or procedure. And you certainly can look at real world evidence, but that requires assumptions and more uncertainty, and often we just don't see as many studies that are out there. Also with services and procedures, we typically have more of these, what you might call clinician effects or learning effects, that the effectiveness of a procedure really could be tied a lot to the skill of the surgeon or the evidence that's available in a particular geographic location that might be different than another location. So experience tends to matter more with services and procedures than with drugs, and there are exceptions. But another reason why we might not have as much data. And on the cost side, and we've heard this from Brett and Chris, a lot of variation in terms of regional costs. And of course, there's some variation in terms of drug costs and how different regional players negotiate prices, but probably just a lot more in terms of cost. There are certainly other data issues we might come back to, but I'll highlight those. And with that, I'm going to turn it over to Dan.
Great, thanks, Peter. And just waiting for control here. Looks like I got it, great. So thanks, Mark and the Altarum team for the invitation today. Happy to be with you and to continue to speak about this. So the other element that Peter mentioned is the nature of the intervention. And of course, with drugs, we know, and if we didn't know, we certainly heard a lot this week about the fact that prescription drugs get temporary monopolies when they enter the market. And so there's a clear incentive for companies to try to demonstrate the value of their product to justify the price. And so there is that incentive for value demonstration. With services and procedures, we don't have that. So there's typically no property rights involved with a service or a procedure, possibly with some devices, but that's really it. If there are payment mechanisms that are in place to align price with something, it's typically with cost, not with value. And so it's a very limited view. And then, of course, because services and procedures don't go generic like drugs do, there is no near-term incentive for that value demonstration. And in addition to the variation that the other presenters described, what obviously you see with non-drug interventions is that prices continue to go up and up. So what to do? We have a number of thoughts about this. So Peter tells me I'm not allowed to participate in a webinar unless I use it as an opportunity to promote the book that he and I co-wrote together with Josh Cohen, our colleague at Tufts. A little bit tongue in cheek, but really only half in jest here, because a lot of the issues that we discussed in the book, from the history of early health technology assessment efforts in the US through to methods development and evolution, really have a lot of applicability to other areas beyond drugs. So all this to say, there is a groundwork that's already in place to begin to think about this and to extend some of the methods. So what about HTA? Well, my former employer, the Institute for Clinical and Economic Review, really got its start doing reviews of clinical evidence, cost effectiveness, and budget impact of therapies outside the drug sphere. And so up until 2015, most of the interventions studied were health system level devices, imaging procedures, et cetera. Since 2015, and we all know about drug prices as a central area of debate, ICER has pivoted, and really 3/4 of its reviews at this point since that time have focused on drugs. They've recently announced a commitment to begin doing more non-drug reviews moving forward as well. But this is one organization privately funded. And in terms of all of the services and procedures that might need a cost effectiveness evaluation, that's a huge M. So another effort that Peter co-chaired, that I was a panelist on, as was Bill, was a vision for trying to think about a national strategy for HTA, a vision for the future. Really, a set of recommendations were developed to try to move the field forward, but also to think about how HTA could be applied broadly to drugs and non-drug interventions alike. And so we really ended up with the idea of a federally coordinated center that would still involve organizations like ICER, private sector organizations that would conduct these HTAs, but really think about the value question across the entirety of the health system. That was our goal for this vision. So that's, if there's potential for that goal to be realized, we think it should be applied across the board: drugs, services, procedures, etc. But there are other things that other stakeholders can do as well. Private payers are kind of a sometimes consumer of cost effectiveness evaluations, but they can also be much more involved than they have been. One opportunity might be to augment these initiatives. So Mark mentioned choosing wisely at the top of the hour. These initiatives that have identified low value care primarily using clinical criteria, and augment those with cost effectiveness analysis. So some work that David Kim at our center, and Peter and I were involved in this as well, some work that David led, looked at how some of the choosing wisely low value designations were made. Some of them, a pretty healthy percentage of them, were made based on the cost of these interventions. And it's certainly the case, those of us who've been around CEA know that high cost interventions may not equate to a definition of low value. In fact, they may be high value because of the benefit they bring to the patients. And similarly, low cost interventions may be poor value. So adding CEA provides a much more explicit ability to try to understand the value brought to the patient and to the patient's family. Another thing to do would be to add technology adoption activities that are similar in some ways to what you might see with a P&T committee, a commercial payer. So there's no reason not to do the same sort of thing, apply the same sort of standards to non-drug interventions using a very similar approach. P&T committees are often external to the payer, so they're often independent, but they use fairly detailed clinical criteria for understanding adoption, and they also at times consider cost and cost effectiveness. And then tying that reimbursement to evidence and value. There's a lot of discussion about how to dynamically price or cost out interventions, how to understand how those prices or costs should change based on the availability of new evidence. That's something that private payers could do as well. What about the research community? Well, we know as consumers of and researchers using RWE data sets that they're anything but standardized. A claims database is not a claims database, is not a claims database. There are opportunities for further standardization there. Methods guidance for costs and effects. We heard about some of those earlier, but those can continue to be developed and integrated into CEA considerations for non-drug interventions. And then increases in sponsored research. In some cases, there's no manufacturer to go to, but that means that clinical societies and health systems need to take up the mantle. What about journal editors? So oftentimes what gets disseminated is kind of at the discretion of journal editors. So in general, we find that outside of a few journals, some journals are just not very accepting of cost effectiveness analysis in general. They can take some steps to prioritize service and procedure-based CEA, potentially over drug CEA in some cases. And there can be calls for papers and special issues that would essentially help seed the field further to bring in that information. So those are some things that we think can be done. Some of them are near term, some of them are longer term, but there definitely is potential to increase the use of CEA to help with decision-making and understanding trade-offs with these interventions as well. So with that, we thank you for your time and we'll take any questions.
Hey, Dan and Peter, thanks so much. Of course, you intended this perfectly to take 14 to 15 minutes because there's lots of really tough questions coming your way. But I'm just going to go for a plug because you know we've been thinking about this for a very long time. Tell me what, I don't think you could address the homogeneity and issue of pharma compared to heterogeneity for procedures. You've written about that for years. I'm not going to bring up the issue that costs of drugs tend to fall over time and cost of procedures go up over time, but I am going to ask something that you've heard me say before. What can you do with your registry over that? I like to talk about the stepchild of the four corners of the 2x2 table. In those interventions that you looked at, pharma and procedurally, that fall in the are more expensive and actually provide no clinical benefit. The fruit below the ground of low value care. Is there something that the community and the consortia that we work with can work together with you to bring more attention to the fact that would tie these first several presentations together, that we don't need any more research to say we don't need to do knee meniscotomies or stenting in certain situations, or as was published last week in JAMA, that there's millions of dollars being spent on drugs where there's no clinical indication.
Well, certainly we can and should continue to shine a light on it. And we do that by, showcasing these studies in our registry and, showcasing high quality studies that are perhaps more credible and believable and useful. But, as you know, and I think Chris made the point too, information alone is necessary but not sufficient. We need to couple that with changed incentives. If we don't change the incentives, the people who provide care that maybe is not efficient may continue to do so because they get reimbursed for it. So, I think we, and you know this better than anyone, Mark, but we do need to have value-based insurance and other incentive-based approaches to drive behavior and provide the information too.
I wish we had you guys longer. Dan, you're going to have to learn to speak quicker like a true Bostonian.
Sorry.
Go ahead, real quick.
I was just going to say, so those upper left quadrant interventions you're talking about, Mark, so this is an issue of publication bias in some ways. So who wants to publish that information? Who's sponsoring the research? And is that the message they want to get across? So again, I think it comes down to the sponsor. If there's a sponsor who's really interested in understanding those higher cost assessments, right, higher cost interventions, and the challenge in that they don't bring value or they bring less value than what is out there already, then they've got to fund that work.
Got it. Well, the curve for low value care papers is similar to that exponential curve for CEAs. Thank you, guys. And Dr. Dos-Reis, we're not going to take away any of your time here. So thank you, Dan and Peter. Next presentation is Health Technology Assessment and Methods for Evidence Generation on Patient-Driven Values in Healthcare Services. Dr. Dos-Reis, the forum is yours.
Thank you so much, Mark. And you did a fabulous job pronouncing my last name. Not many people have that ability. So appreciate that. Hi, everyone. And I'm Susan. I'm professor at the University of Maryland, also co-director of the PAVE Center. I'm joined today by my colleagues, Dr. Julia Slako, who's co-director of PAVE Center and also associate professor in the department, and Dr. Alejandro Emilio Rosario, who's a postdoctoral fellow working with us at the PAVE Center. We're really happy to be part of this webinar and thank Altarum for their support to be part of this. Next slide. I'd also just like to briefly acknowledge that PAVE Center is funded through a grant from the Pharma Foundation. And we really do rely quite a bit on the patients and the patient communities that have really supported a lot of the work that we've been doing, and some of which we'll show you today. Just for set the stage for today, our objectives for the webinar and presentation today are to illustrate how stated preference methods can be used to quantify patient values for different attributes of a treatment, and in particular also healthcare interventions. We'll also explore the potential for translating these patient-centered patient values into patient-centered economic evaluation, and then discuss this in the context of evidence generation for patient-centered health technology assessment. Next slide, please. Here, we're going to briefly today illustrate how we actually apply the following steps in developing an instrument to measure patient preferences. And starting with really identifying the elements of value and things that are most important to individual patients, and engaging patients along the way to refine our tools so that the measurement tool best reflects patient decision making. Next slide, please. Here on this slide, I just illustrate and provide some background to really what is the foundation for some of the work that we're doing. And it's grounded in the patient-informed value elements, which the team at PAVE work very closely with patient stakeholders in the community to identify the domains and areas that were most important and key considerations in healthcare decisions. So what we have identified were 5 key domains. And in all, there were 42 value elements across those 5 domains. The paper here was published in 2020, which explains how we generated those domains and also illustrates a conceptual model that underpins a lot of this work. As you'll see here, these elements in this framework is not specific to any one condition. It's actually condition agnostic. And the importance of that is that we're able to then apply this to a range of situations, and it can be tailored to any number of healthcare interventions. And currently, Alejandro is leading a project to assess patient values for telehealth care, as that has become much more prominent in our healthcare system. So from here, I'm going to turn this over to Julia. She's going to walk you through some case examples to illustrate how we're able to apply these elements in an empirical research to assess patient value. So Julia, I'll turn that over to you.
Great, thank you, Susan. Okay, so I'll talk about a case example of how we are prioritizing and also tailoring these value elements for the development of a preference measurement instrument in order to then later quantify these different value elements. So we do have a number of ongoing projects that address both mental health and physical health, so different conditions. And as Susan mentioned, the value elements are really disease agnostic, so that we can apply those elements to a number of conditions. And in these different case examples or these different projects that we've had so far, what we found is that the priorities of the patients really apply to both aspects of the treatment and outcomes, but also aspects of health services too. In particular, many of the elements that we've heard have been important to patients address aspects of treatment and outcomes, of course, but also elements of care delivery. So you can see on this slide an example of an activity that we used for our project in COPD, which I'll explain in a moment. So we are thinking about, as we hope to see an increase in the evaluation of health services, that some of these patient-centered elements can actually play a role in those evaluations as well, because now we do have this set of elements that are not specific to treatments per se or attributes of a treatment. And also I'll mention that while not covered here in our slides, our blog post discussed a little bit more about applications for telehealth. So the example that I'll present now is about chronic obstructive pulmonary disease. So the goal of this project was to find out from individuals living with COPD, which of those long list of value elements of that list, which were the elements most important to them. So through a number of guided activities that we mainly conducted online, we were able to then identify a handful of elements that we saw emerging as being really important to these about 24 participants who were enrolled in our study. So I've presented here a reference to a paper that really describes in detail the study and what we did. And you can see that just an excerpt of the activities on the left-hand side. So there were 5 activities, and some of the activities were specifically about attributes of treatment and outcomes that are important. But you can also see that some of these attributes could apply beyond just some of the specific elements related to the treatment itself. And we think that they do apply to care delivery as well. So next slide, please. So once we learned about the elements that were the most important, as I mentioned, there were about half a dozen of those, we wanted to refine the elements so that we could include them in our preference instrument. And for that, we really want to make sure that the attributes that we include and the phrasing of those levels are really relevant for the condition. And so again, coming from a list that starts out as being disease agnostic, some of those elements or the way that we discuss them in these instruments may not really make sense for the condition. So using an iterative process where we again enrolled participants, and some of them were from the original participants from the first phase of our study, as well as some additional patient advocates. We enrolled them to refine this list, make sure that we weren't missing important elements, and also consider how these specific elements related to the condition. Again, with a goal of operationalizing this for a preference measurement instrument, and then something that we may later on be able to adapt for health technology assessment, cost effectiveness analysis, et cetera. So thinking about side effects, for example, that was one of the things that was most important to patients. We might think about, well, it's easy for us to operationalize these for our model or for an instrument as being mild, moderate, or severe. But in fact, patients are really more concerned about how they would handle side effects, whether they would need to add another medication or not, or how would they deal with side effects if they occur. And so that speaks to some things outside the specific treatment itself, but other aspects of care delivery potentially, or other ways that patients access care that are going to contribute to the value of whatever intervention we're assessing. So it is important to operationalize these in a way that makes sense for the condition and for those patients. So interestingly, some of the elements that were most important to patients with COPD, so there are a couple on here, side effects and physical abilities were really key elements, but other things that they really cared about are ways that patients interact with their provider and where they get medical information. And so just knowing that those elements are important really speaks to possibly applying our findings here for the evaluation of educational programs, for example, for inhaler and medication use, which is really an important part of treatment effectiveness for COPD. Next slide. Okay, great. So let's see. Sorry about that. Okay, so after this iterative process, then we had these 6 elements as attributes with 3 levels for each of these attributes to develop into a preference measurement instrument. So this tool is used to then quantify the preferences by creating these decision profiles, which you can see an example of how this works on this slide. So presenting participants with these profiles and asking them to choose a single profile then forces them to make a choice and trade off some of the benefits and risks that are presented in the profiles. And that allows us to then quantify whether they would be willing to pay more to avoid specific side effects, or willing to pay more to access aspects of their care that they prefer, etc. We might also be able to observe heterogeneity in preferences across different subgroups, because in addition to presenting these profiles, we also collect a lot of information about conditions through clinical questionnaires and so forth, and other demographic data. So at this point, why don't I turn it back over to Susan, and she can let you know a little bit more about the quantification.
Next slide, please. Thanks, Julia. So, as Julia mentioned, because we are providing people with a profile, and they have to choose a profile and weigh the options within each profile, we're able to analyze these data, and through the analysis, with the conditional logit, we use the beta weights that really are the mean scores for each of these attribute levels, not just for the attribute. So we're able to then plot this data and visually inspect how different the betas are across the different attribute levels. And when you see large differences, as you do where the call-out box is pointing to, you see that changes in a level of a given attribute can have a pretty dramatic change in someone's preference for that particular level of the attribute. So they may not dislike the cost, but at a certain point, where is the threshold for then when cost becomes beyond what they're willing to accept? And anything above the line would suggest that those are attribute levels and that would be preferred, and anything below the line would be things that are least preferred in their choices. And as you can see, some of those betas might hover around the line, which would suggest that changes in the levels of that attribute don't necessarily change someone's preference for or against their selection. And so we are able to use this data to then assess the relative importance of different attributes. And the graph on the right shows how we can then plot that. And with this information, it really gives us a little bit more detail as to how individuals may be trading off, say, cost for an outcome. And it allows us to really do some calculations that we can empirically derive what that benefit risk or that cost benefit trade-off would be for these individuals. So with this quantification, this is where we want to really explore the next step. And I'll turn that back to Julia, as she's thought a lot about how we can then move this into HTA.
1 minute remaining, Julia.
Okay, thank you. So in the interest of time, I will just quickly wrap up and just mention, a couple take-home points from our findings with COPD. We're thinking about, what we heard back from patients. I think the top row of this little table talks about, things that we learned from patients that are important. Some of those things we might already have methods to address pretty easily. Some of those elements are more novel and could be challenging, but things that we're considering how to address those in evaluation. And the other thing that I think was a takeaway for us is learning about the things that are important to patients can then inform how we would take on evaluations of things that are beyond specific treatment, such as pulmonary rehabilitation and things that do include more access to care and relationship with provider and so forth, because those were quite important. So, and we think about engaging patients and developing some of those evaluations and also thinking about the health states that are important to them. So with that, I'll conclude, and we'd be happy to take questions if there's a moment.
Well, thank you. I think you'll see some opportunities for folks to ask questions in the chat. You took your 15 minutes. I'm really interested in the idea of patient heterogeneity, particularly seeing the craziness that occurred with the COVID vaccine. But I do thank both of you for a really interesting presentation. Holly, can I have the next slide, please? I'm really pleased to bring up a colleague of mine in this multi-decade journey in value, long before it became both a alliterative and very popular. Eleanor Perfetto and her colleagues from the National Health Council to present on a blueprint to advance patient-centered core impact sets. Eleanor, it's a pleasure to have you on the program.
Thank you, Mark, and thank you to Beth and Altarum, the Altarum team, for inviting us to participate in this. So next slide, please. I know we have limited time, so I'm going to jump right into it. So the background here, our goal is accountability for all. If we have accountability for all stakeholders to make care affordable and high value to patients, we have to ask the question, but what is high value to patients? Because we very often don't know, and we haven't been doing a very good job of collecting that information. Next slide, please. So we have a current environment, which includes a very haphazard approach at targeting what to measure for different diseases. There's numerous measures, there's numerous endpoints used in trials to study and monitor health. These things are often misaligned with what patients report matter to them. And we have to ask the question, are these measures that we have capturing value? So we want to know what really is high value to patients, what should be measured and monitored. Next slide, please. So we get down to the problem of we have misalignment. We have misalignment between what patients tell us is important to them and the data that actually gets collected. And then we end up with misalignment between the existing data that we're very often looking at and the data that we really need. And the result is that we see that patients' views are often not considered, the right data don't get collected, and data gaps are identified, but they're very often not filled. So very often we see that we recognize that we're not collecting what's important to patients, but we're also not filling that gap. Next slide, please. Our solution that we have in terms of moving this forward is patient-centered core outcome sets. And so we have, at the National Health Council, have begun an initiative focused specifically on this with some very specific partners, and they're recognized as the authors, my co-authors on this project. And it's to come up with a patient prioritized list of the impacts a disease and or its treatments have on patients, carers, and families. And they serve as a guide for a multitude of downstream uses. And I think we've heard a lot about the downstream uses earlier today in some of the previous presentations that we heard about how these could be used and how these could be implemented in health technology assessment and value assessment. Next slide, please. So our project, here's an overview of our project. Our effort is a multi-stakeholder effort to create a blueprint and toolkit that the patient community and others can use to develop patient-centered core impact sets for a specific disease, related diseases, or specific subpopulations. And our vision is that this is an effort that would be led by the patient community. So it would be led by patient groups, but certainly they can't do this by themselves. They can't do this in isolation, and they need to do this as part of patient group consortia with medical product companies, with government entities, academia, others. So that, but we want them to lead it so that the patient voice can be enhanced throughout a number of uses. And this is just a list of a few of the uses where they could be used. So clinical trials, real world studies, value assessment, economic modeling, quality measure development and quality measure studies. So all of these places where we could actually have everyone concentrating on the same targets rather than going off and looking at different measures, different endpoints. Next slide, please. So first step in what we're doing is we created a framework. And the framework is one that was put together by the advisory committee that we put together, a multi-stakeholder advisory committee. And we begin with the idea up in the upper left-hand corner that there's a pool of potentially important impacts that patients might report to us if we ask them what was most important to them. And the gray indicate those that are really those direct health impacts, the ones that we're very used to thinking about in terms of outcomes, symptoms, death and mortality, adverse events, signs. Could also include biomarkers and surrogate markers, so things that we more commonly measure. And then there are the blue bubbles, which are the things that are a little bit more distal from those direct impacts, but they can be just as important, if not more important to patients. Financial considerations, career, personal goals, care and family stresses and burdens, and many, many other things, as certainly my colleagues from PAVE talked about in the previous presentation. So it can be lots of other things that can be impacting their lives every day. And then there are a lot of other important considerations like equity, representativeness of the patient population, social determinants of health, health literacy and numeracy, culture, religion, and other kinds of baseline characteristics that we always have to be conscious of. We put those through a process, and we have to think about patient care and family engagement to really get at from patients what are the things that are most important to them. So from this larger pool, how do we get down to those things that are most important? And it would entail engagement of those populations. And it also could be formal ways of identifying this information through preference studies and Delphi panels and those kinds of things that really get us to what is most important. And you see those little bubbles there, the light blue and dark blue bubbles that get to what are the things that they tell us are most important. That would feed then into a prioritization process that gets us to that core set, because we also want to think about other stakeholder engagement, what we might learn from an environmental scan represented by those squares instead of bubbles. And then we put them through that process to come up with, of all the things, potentially many things. For example, maybe it's 50, maybe it's 40, but to go from all of those down to what's really the core set that should be monitored and be the focus, be that target for most of these other uses. So we get that down, and you'll notice there that we started off with 6 bubbles as an example in the center of the slide for those things that are most important to patients. And when it goes through that prioritization process, we maintain that those 6 things still have to stay in there, because we don't want the patient's voice to be outweighed or outvoted by the other stakeholders who might be involved. But then you see at the end, those things that we come out with as the core impact set funnel into those possible uses. And I said, this is just an example of what those uses are. The main takeaways from this process, that it would be patient-led and patient-driven. We want them to have an active role, but they wouldn't be the only ones doing it. It would be multi-stakeholder. It begins with patients at getting what's most important to them, where previous initiatives begin with looking at the literature. or thinking about what other stakeholders think are most important, or thinking about the uses and thinking about how everything is use-driven rather than patient-driven. And we want to make sure that we're starting with patients. Next slide, please. So our plan and our timeline. As I mentioned earlier, we have a multi-stakeholder advisory committee, and we have completed an environmental scan. We wanted to ask the question, do these core impact sets, the way that we're defining them, already exist? And then what are the resources out there that exist that could support core impact set development? We've come up with foundational principles. We have drafted the blueprint outline, so our table of contents really for what these documents will look like. We've established 4 working groups. One of them is concentrating on the background, which is the why of core impact sets. Another is concentrating on the methodology that should be used. A third is looking at the resources and looking at what that toolkit will look like. And then the fourth is a group that's thinking about pilots and use cases. Next slide, please. This is a sample of what our draft principles look like. It is going through a review process right now. And as you would expect, the process begins by engaging patients, care partners, and families to identify what's important. Next slide, please. Our early environmental scan findings, patient-centered core impact sets, as we have defined them, do not currently exist. So we have not found anything that looks like this. And so we found some other things that are similar and that certainly are aligned, but as we've defined them, are not identical. And so as I said, we've recognized that there's a multitude of resources that exist and that can be leveraged for developing the blueprint, for creating a taxonomy of what these impacts could potentially be, and then supporting blueprint implementation and uptake by researchers and others who might use them in various uses. Next slide, please. Our plans for 2022 and beyond, we hope to have the draft of the blueprint ready for the spring. We will begin pilot testing as soon as the draft is ready. We have applied for funding for conferences for the summer of 2022 to have a public comment period and a public comment conference at that time. We hope that the refined blueprint document, the finalized one, will be ready by fall of 2022. We will be refining it based on the pilot testing. We will be continuously disseminating information to socialize the idea, gain support for it, encourage use and uptake. We will be thinking about what's the infrastructure and the methods development and the maintenance that needs to happen with core impact sets. And we've actually begun thinking about that already in terms of encouraging multi-stakeholder engagement in that infrastructure and methods development work. And then the next slide, please. I have a couple of use examples. So for example, very often in value assessment, we talk about the lack of data on the impacts patients care about. And many of the previous speakers have mentioned this. And when you're doing value assessment, you really need 2 important things. You need to know what those impacts are, and you need to have data that captures those impacts. And a core impact set, a patient-centered core impact set, can provide the value assessors guidance on what should be included in their work, what is important to patients. But then over time, hopefully, because we will have established the core impact sets and have identified what they are, if the data do not exist or the measures do not exist to capture those impacts, then hopefully researchers can be encouraged to fill those gaps and the value assessors can get the data that they need over time. Next slide. Another potential use is in real world evidence. So for example, in the LEAPS initiative that is part of the MIT New Digs, there's an ongoing rheumatoid arthritis pilot as part of LEAPS. And one of the challenges that pilot identified was that there is really a lack of consistent patient important impacts that are embedded in those upstream data collection efforts. And they had to develop and use proxy measures for how patients feel, how patients function. And so patient-centered core impact sets could help address this gap in RWE and have spillover effects into other uses. Next slide, please. Just to wrap it up, we believe that a blueprint to develop patient-centered core impact sets will establish a consensus-based approach for how patient-centered impacts are collected, measured, and prioritized for a particular disease or population. It can potentially improve understanding of data that should and could be collected across all diseases or groups of patients. It can provide support and assistance to healthcare stakeholders by identifying impacts beyond the clinical impacts, because we use the the term impacts intentionally to encourage people to go beyond thinking about what's only clinical, but what else, many of the other impacts that patients care about, and what could and should be collected in a patient-centered approach. Again, I want to acknowledge the partners that we have, oh, there's some an error there, but I want to encourage I want to recognize the value, the IVI, the Innovation and Value Initiative, and the Every Life Foundation. They are two of our founding partners who really helped get this off the ground, and I want to acknowledge their contribution. Thank you.
Eleanor, congratulations. This has been a multi-decade effort on your behalf. Standing ovation here from Ann Arbor, and so important to your emphasis not only on patients, but families and caregivers in all these initiatives. Lots of initial reactions, one of which is, I'm not sure there's an answer to this, but the current status quo, as limited as it is so complicated and controversial. Where do you see how this most important initiative, in my opinion, if you don't know how patients value interventions, then it's not even worthwhile doing value calculations. But where do you see this fit into the existing status quo, and will it be such a disruptor that it may be hard for implement? Have you thought about how this is going to fit into the puzzle that we've been working on for all these decades?
Yeah, I actually think that we've been doing some things right, and so they will fit into this. But for the things that we haven't been doing well, it can help guide the field in the direction of getting it right. So when we really haven't identified what's important to patients, or when we've only partially identified what's important to patients, we can do a better job if we all are working from the same targets, if we're all working from the same core impact set list. Then at least it gives us that, I think it was Bill and Peter early on in the presentations who said there really isn't common purpose and definition. It can help us in some way to get to some element of common purpose and definition. And I think, Brett in his presentation recognized, the fact that we don't very often don't get this right because the data are just not there. And, I've seen efforts where the impacts that are important to patients get identified, but then the list or half the list gets thrown away because we throw up our hands and say, well, we don't have measures for that. Well, the fact that it's on the list and we don't have measures for it means that it should be part of our research agenda to get the measures to fill those gaps, rather than just toss that part of the list away because, people throw up their hands and say we can't measure it. So I think
this audience would be extraordinarily interested to see how information gleaned from a program like yours would change the results of a highly accepted cost effectiveness analysis that didn't do as good a job as you may have. So this is, we're going to be watching you very, very carefully. Congratulations, and looking forward to progress in 2022 and beyond.
Thank you.
So we're going to close out today's session with colleagues from St. Louis University who will be talking about leveraging community benefit to increase the value of healthcare. Again, stepping away from pure clinical and engaging beyond the more traditional medical measurement and extending to the community. Michael Rogier and Kimberly Aynard, you get to close us out. Thank you.
Thank you, Dr. Fendrick, and thank you for the invitation to participate in this forum. A couple of quick disclosures that I do serve on the board of directors of a nonprofit health system, and Dr. Aynard, that's an uncompensated position, and Dr. Aynard is a paid consultant for a couple nonprofit hospitals in the community benefit space. So let's begin on the next slide with a little bit of background for those who might be a little unfamiliar with community benefit. Historically, it arose kind of out of the Hill-Burton Act in the mid-century, where those receiving funds for hospital construction promised to provide care to those who are unable to pay for care themselves to the degree that they could. And it was a very ambiguous definition at that time. It has since been structured a bit more rigidly, and it really has emerged as the primary justification for tax exemption for nonprofit health systems and hospitals. The best estimate is that We spend about $64 billion a year, which kind of in the big picture of healthcare might not seem like all that much, but I view it as kind of free money. It does not have to go into any particular place. And so we get to choose freely how to spend these $64 billion, which makes the question of value really exciting, because we get to hopefully identify those places where this large amount of money can achieve the greatest value for our healthcare system. The vast majority is devoted to clinical care services, about 84%, and that has remained steady since some of the initial studies. The probably most prominent one we've graphically displayed here in 2013 from New England Journal of Medicine. You can see that around 84% is devoted to clinical care. There are other things, community health improvement. There is health professions education, it can be research, and it can be in-kind contributions. The other kind of important note here is that about 8% of operating expenses on average are devoted to community benefit from nonprofit hospitals, but there is significant variation in this figure. So some systems or hospitals are spending 1 to 2%, while others are spending well above 10% of their operating expenses. And we actually linked to a very good study in that in our blog posting, which you'll have access to soon. And interestingly, the Affordable Care Act, the Senate held hearings in 2008 regarding the nonprofit status of the hospitals to kind of more significantly rein in the idea of community benefit. And the Affordable Care Act was a response to that as well, where we have to now do triennial community health needs assessments and more clearly articulate the spending that goes on. I'm now going to hand it off to Dr. Renard so she can talk through the reporting mechanisms that are now associated with community benefit.
Okay, thank you. So hospitals are required by the IRS to report their expenditures for activities and services around community benefit. These are reported annually on a Schedule H. And importantly, this particular form has specific criteria for reporting, and this helps to ensure that data are reported consistently and in a standardized way, which enables some comparability across hospitals. So as indicated at the top of this slide in blue, most of the benefit related expenditures are allocated to patient care, as Dr. Rozier referenced. For example, charity care, unreimbursed costs for means tested government programs such as Medicaid, also financial and in-kind contributions to community groups. Other activities, as shown at the bottom in yellow here, can be reported, but organizations have historically not seen much benefit in terms of their reputation in doing so. These types of community building activities may focus on housing, economic development, or coalition building, for example. Next slide, please. So here we have an annotated version of the World Health Organization's conceptual framework for action on the social determinants of health. And so moving from left to right in this diagram, conceptually from upstream to downstream, the framework shows how social, economic, and political structures give rise to socioeconomic positions that are based on certain factors that we're all familiar with: income, education, occupation, et cetera. And we know these are really important structural factors that determine health. And then continuing to more downstream, these underlying social determinants influence some of the material circumstances that people are living with on a day-to-day basis, and then ultimately the downstream health and well-being outcomes. So as here is highlighted in red, hospitals rarely engage in community benefit activities related to public policy other than those issues that directly impact healthcare delivery. However, some of the community benefit activities in this space may include some efforts to increase civic engagement to the extent that nonprofit organizations can do so. And then highlighted in yellow, we see community benefit activities that are occasionally undertaken by hospitals. Examples would include supporting early childhood education, or perhaps using the hospital's status as an anchor institution in the community to increase the prevailing wages or increase local purchasing. Increasingly, hospitals are also doing this through workforce development efforts, such as hiring and training local community health workers to serve as patient navigators or peer coaches. And some of these positions can lead to career growth and economic security for the workforce, and as well as increased access to educational opportunities. And then the most commonly undertaken community benefit activities are aimed at addressing some of these intermediary determinants of health, which are highlighted in green here. So these activities would include supporting community gardens and kitchens, and perhaps school-based nutrition and exercise programs. They may also include activities that are designed to directly address barriers to care, such as transportation and insurance enrollment, or other social or psychosocial barriers. Hospitals have also focused on supporting community groups that are working on similar health issues. So collaborate rather than starting something from new. And they can do this through providing small grants and perhaps training programs to these organizations. I'll pass it back to Dr. Rozier.
Great. Our final two slides here. And so one of the questions that we're faced in terms of community benefit is what incentivizes activity? And one of the things that we raised earlier is that there's this difference in the Schedule H Form 990 between community benefit activities and community building activities, which for those of us in healthcare might seem very strange, that a hospital can count something like a community garden or charity care, but they can't count workforce development, environmental health, some coalition building activities. And so if we're trying to incentivize behavior, especially on upstream activities, we're gonna need to kind of be more attentive to where the benefit is located. In addition, in a fee-for-service environment, whenever hospitals successfully prevent patients from walking through the doors, that's a very good thing, and most hospitals are very committed to that. But we do have to appreciate that it's not until we fully transition to a more value-based framework that the incentives are going to fully align. Also, in a lot of these activities, the time horizon is much longer than we are used to in healthcare or in any kind of advocacy space. So we might have to be using other proxy measures for effectiveness, maybe process measures or output rather than impact. We also need to be careful about the balance between efficiency and equity, because there are going to be some interventions that are really important for groups for which it might be less cost effective, right? You can think of minority language groups or rural communities. It might be less cost effective to do interventions there, but it's really important for equity reasons. And we've also lifted in the blog post, we've adopted the clinical nuance, which VBID has been so good at kind of making public, and talk about community nuance. And so how do we understand that there are certain situations in which these community benefit interventions are going to be effective based on who delivers them, to whom they're delivered in the context that they're delivered, and other situations in which they're not going to be effective. And the final slide, just a couple recommendations summary that require evaluation of more community-based programs, which is not all that common. Hospitals have very little incentives to meaningfully evaluate and publish what is effective and not. Encouraging community building in addition to community benefit activities, and figuring out ways to align the incentives for providers, especially with preventative care. And with that, we will take any questions that people might have.
That was terrific. And what a great way to close out our seminar today. The Gateway Arch gives me some optimism. I think there's, again, so many things to discuss. Dr. Einard, the question that comes to mind is, how confident are you that the reporting that you're using is actually as accurate and complete as we would hope?
Well, if you're referencing in terms of what the hospitals are reporting, I think a lot of it comes down to they're following guidelines and procedures to ensure that they're reporting the numbers the way that they're intended to be reported. But I think some of the issues come down to how, are the things that we're reporting the most meaningful things, as Dr. Rozier commented, sometimes perhaps the incentives to do certain activities versus others is based on what we're reporting and how easy it is to report those things. So I think that, that is an issue. And I will say that from working with some community benefit organizations on evaluating their programs, I think that there's definitely a lot of room for improvement in data collection, particularly with regard to the effectiveness of the activities that are being delivered.
I think that derives from, and I apologize for the little bit of skepticism from the audience, seeing how unimpressed many of us have been in terms of the implementation of the federal price transparency rules from hospitals. So it sounds like you're a little more confident that they're doing their job and have confidence in providing the information that you would need to be able to, make the recommendations you've made.
Yeah, I think, Father Rozier, go ahead.
I would say I think we're pretty confident in the charity care numbers or the things related to clinical care, because as we know, the financial systems in hospitals are trained. People are tested and expert in that space. What the expertise is absent within most hospitals and health systems is how do you kind of account for the other programs, especially the community building programs. And there I've seen quite high variation in the estimates of what they end up counting as part of community benefit.
Thank you both so much. And I want to thank all our speakers and all of you, the audience, and certainly Beth Bowden-Seiler and George from Altarum, my close colleagues in this value pursuit. You'll be hearing from all of us in terms of follow-up from this webinar, and you'll be getting regular reminders about publication of the blog posts, and I look forward to reading all of them. So with that, I want to thank, again, the speakers, the Altarum folks, and Pharma for supporting this, and look forward to next time we gather, hopefully next year.